Did you know that over 20% of NCLEX questions can involve pediatric concepts? It's a huge chunk of the exam. So let's dive right into this explainer and master some of the most high-yield pediatric nursing concepts out there. Look, if you're preparing for your NCLEX, you already know that pediatrics can feel like an entirely different language. I mean, children aren't just little adults, right? Their bodies, their milestones, the way they react to being sick, it's completely unique. So today, we're focusing on exactly what you need to know to absolutely nail those tricky test questions, from the absolute safety priorities all the way down to normal developmental stages. Let's get into it. We're starting things off with a massive NCLEX trap. Take a quick pause and really think about what you would do first in this dramatic clinical scenario. Are you checking their temperature? Maybe looking down their throat? Actually, no, neither. The tripod position allows a toddler to find a position of comfort and open up their airway. Seeing a kid in this position is a massive red flag for respiratory distress. Your absolute first priority here is protecting that airway and prepping for an emergency intervention. Always prioritize the ABCs: airway, breathing, circulation, especially when you see a child instinctively positioning their little body just to pull in oxygen. All right, Section 1, Core Concepts for Infants and Toddlers. Let's build our foundation, starting with our youngest and most vulnerable patients. When you're establishing baseline assessments for newborns, cranial structure is a massive target for questions on your exam. You've got to know those anterior and posterior fontanelles. The NCLEX absolutely loves to test your knowledge on normal versus abnormal findings here. So here's a quick memory trick for you. The anterior is shaped like a diamond and closes after, so around 12 to 18 months, while the posterior is a triangle that closes promptly at 2 to 3 months. Assessing these soft spots, along with measuring head circumference, is totally crucial. If they're bulging, well, you're looking at increased intracranial pressure. But if they're sunken, you should be immediately thinking about dehydration. Now, by chunking gross motor milestones across these specific ages, progressing from crawling up to climbing, you can quickly use pattern recognition to spot a developmental delay. It's way easier than memorizing a textbook. Notice how the timeline naturally progresses from simple, large muscle group coordination to much more complex actions. For instance, climbing is a major gross motor skill that pops up in toddlerhood. Test makers don't want you to just recite facts. They want to know if you can look at a 2-year-old who can't walk independently and instantly recognize that as an unexpected delay that needs intervention. Here's another crucial point. Knowing that regression during periods of stress, like toilet training or being hospitalized, is entirely normal for a toddler. It is not an immediate red flag. You're for sure going to get scenario questions where a 3-year-old who is fully potty trained suddenly starts wetting the bed when a new baby sibling arrives or they get admitted to the pediatric ward. Listen, this is normal regression. It's a completely expected behavioral challenge, right along with negativism, which is them saying no to literally everything, and temper tantrums as they navigate Erickson's stage of autonomy versus shame and doubt. Don't confuse these normal, everyday coping mechanisms with a true cognitive or physical developmental delay. Moving on to Section 2, Priority, Safety, and Alerts. Safety is always the ultimate NCLEX priority, so let's break down the most common traps you'll run into. When it comes to sudden, unexpected infant death prevention, the rule is incredibly simple: stark, empty, and safe. To a parent, a crib stuffed with pillows, thick blankets, and cute stuffed animals might look super cozy, but to a nurse, that's a glaring safety hazard. The safe way, and exactly what you need to teach parents, is a firm mattress, a fitted sheet, and absolutely nothing else. No bumpers, no extra toys, the whole shebang needs to be empty. Recognizing this instantly isn't just going to score you guaranteed points on your exam, it's literally going to save lives in practice. Because car accidents are a leading cause of death for children, getting car seat usage right is a non-negotiable safety alert. You have to be able to instantly recognize this on a test. The chest clip must sit exactly at armpit level, right across the sternum, not sagging down by the belly. Incorrect placement can cause severe, life-threatening internal injuries during a crash. So when an exam question asks about discharge teaching for a newborn or a toddler, car seat safety is very often your top priority answer. Connecting right back to our hook, remember that toddlers are notorious for foreign body aspirations. They explore the entire world with their mouths, and they don't have full chewing capabilities yet. So it's incredibly common for them to aspirate small objects. And these objects frequently lodge right into specific airway branches, namely the right and left main bronchi and the trachea, which requires immediate intervention. If you get a question about a suddenly coughing, gagging toddler with unilateral diminished breath sounds, well, your mind should immediately jump to foreign body aspiration. All right, Section 3, Core Concepts for School Age and Teens. Let's shift gears to the older kids, where the testing focus moves heavily towards psychosocial milestones and more complex health concerns. You're going to see a lot of questions about physical changes, so anticipating the eruption of permanent teeth is key. The school age period, so roughly ages 6 to 12, is when kids start losing their deciduous or baby teeth. As a nurse, you need to know this is a totally normal part of physical development, but it's also the perfect time to reinforce dental hygiene. I mean, considering over 40% of children in the US are affected by dental cavities, it's a huge deal. Sugar intake is a massive risk factor here, so patient education on nutrition and fluoride is absolutely vital. Now, these Piaget concepts are classic test traps. Let's break it down so you never miss it again. When a child sees a cow and excitedly yells "dog" simply because they know what a dog is and the cow happens to have 4 legs, they are assimilating the cow into their existing schema. They're making it fit what they already know. But when the parent corrects them and the child's brain adjusts to realize, okay, this 4-legged animal is a cow, not a dog, that is accommodation. They have accommodated the new information. The NCLEX absolutely loves to test if you know the difference between the two. From bullying causing psychosomatic symptoms in middle school to high-risk substance use in teens, these points serve as your rapid review checklist. Bullying is incredibly prevalent, with about 1 in 3 kids reporting it, and it often leads to physical complaints like mysterious headaches or stomach pains. That is a major psychosocial flag. And did you know over 18% of US children are impacted by obesity? That brings immediate risks of early-onset diabetes. Plus, as we move into adolescence, our nursing focus shifts dramatically to screening for high-risk behaviors, substance use disorders, and mental health challenges like depression and anxiety. Moving into Section 4, the mini NCLEX scenario. Let's put everything we've talked about to the ultimate test with a rapid-fire clinical scenario. Okay, pause and think for a second. What is your absolute priority nursing assessment when faced with a sudden onset of secondary nocturnal enuresis? Read the scenario carefully. The child is 7, and they've been totally dry for 2 whole years. So this isn't just a potty training issue. It's a sudden, unexpected change. What's your move? Do you restrict their water before bed? Punish them? Or do you just reassure the parents that it's a normal phase? If you guessed restricting fluids, actually, scratch that. The rationale here is that you must assess for new stressors or physical issues, like a UTI first. Because the child had already proven they possessed bladder control for years, this is the hallmark of secondary nocturnal enuresis. Your nursing brain should immediately ask, is there an infection? Is there a new severe stressor going on at home or at school? Assessing the root physical or psychosocial cause is always your very first action, way before you even think about implementing interventions like bed alarms or medication. Finally, Section 5, the rapid-fire NCLEX recap. Let's lock in everything we've covered today. If you can just follow these 3 clinical steps when you're answering any pediatric question, you will successfully navigate right around the most common test-maker distractors. Step 1. Always look for the immediate life threat. Think of our tripod-positioned toddler or that unsafe crib. Safety is paramount. Step 2. Don't get tricked by a toddler throwing a tantrum or showing regression during stress. You have to know the difference between expected behaviors and true delays. And step 3. Chunk your milestones. Anchor these ages and stages in your memory using patterns rather than stressing yourself out trying to memorize isolated facts from a textbook. As you prepare for your exams, I want you to ask yourself, are you ready to completely adapt your nursing lens to protect the most vulnerable patients at every rapid stage of their life? Because honestly, that is exactly what pediatric nursing and passing your boards is all about. You aren't just answering multiple choice questions here. You're proving that you can be the vigilant advocate these kids desperately need. So as you head into your next clinical rotation or sit down for your practice exam, keep asking yourself, what other hidden safety risks are lurking out there in plain sight, just waiting for a sharp, observant nurse to intervene? Good luck. You've got this.